Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Servier.
Welcome to this fairly brief summary of this Medscape symposium, which took place at the American Association of Neurological Surgeons meeting in Boston. And this was a symposium dedicated to understanding and discussing the new standards in diffuse low-grade gliomas in terms of the whole integrative management strategy from surgery to treatment to survivorship. My name is Dr. Mitch Berger. I'm director of the Brain Tumor Center and neurosurgeon at the University of California, San Francisco. I'm joined by Dr. Macarena de la Fuente, who's chief of neuro-oncology at the University of Miami Comprehensive Cancer Center in the Department of Neurology, and also by my colleague, Dr. Michael Lim, who's professor and chair of neurosurgery at Stanford University. We started the session with a patient story that essentially covers the journey, a fairly typical journey of a patient who developed a seizure and had a diagnosis of a glioma, had a resection as much as was safely possible, and then was put on a trial of vorasidenib, which is the IDH inhibitor that has recently gained FDA approval. Before we go too much more into that story, and we'll come back to that at the end, I want to cover a number of things that we discussed as part of this symposium. The first is the evolving role of surgery in low-grade gliomas. And to start with, I want to make sure we're all talking about the same thing. This is essentially discussing grade 2 and grade 3 IDH-mutated tumors. Some of them on the astrocytic side have P53 and ATRX mutations. Others on the oligodendroglial side have 1p19q co-deletions along with a TERT promoter mutation. And this can be in the form of grade 2 or grade 3. Now, historically, histology was used pretty much until 2009 with the discovery of the IDH mutation. We'll come back to this in a minute. We see the IDH mutation detected by immunohistochemistry in about 50 to 80% of patients with grade 2 and grade 3 low-grade gliomas. And in addition, we're now incorporating methylation profiling or assays into the mix here because it can further distinguish these lesions in their behavior. So for example, if we see a typical IDH mutated tumor, but it has a CDKN2A or 2B homozygous deletion, then this automatically puts it into an IDH mutated grade 4 category. So methylation profiling is going to become more useful as time goes on. Well, the first goal of this process when we encounter a patient such as what we showed you in the beginning is to achieve a maximal safe resection. And basically what that means is that we're trying to resect all of the flare abnormality in the form of a gross total resection. And we're also trying to go beyond the margins of the flare into what we call a supratotal or gross total resection. And we have done studies, and we've published those at UCSF, along with studies that have been published by neuro-oncology societies and the international-based brain tumor surgical group called the Rano Resect Group. But essentially, from single institution to neuro-oncology societies to the Rano Resect Group, we now classify extent resection into different categories, starting with supertotal resection as class 1. Then class 2 is a maximal resection in which we leave less than 5 cubic centimeters of flare, and a class 3 is greater than 25 cubic centimeters. And the reason to do this is that all studies going forward, including any of the IDH inhibitors, really should involve this stratification from a prognostic point of view. And if we do this, patients who have a gross total flare resection or supertotal resection should result in an overall survival of greater than 15 to 20 years, with also a reduction in malignant transformation. Now, as surgeons, we have a lot of surgical tools to maximize extent of resection. This includes brain mapping to make it a safer removal, and tools during surgery such as navigation, intraoperative imaging, and now Raman-based histology to actually define infiltrating tumor margins to help us maximize extent of resection. After surgery is done, we then determine the best treatment options, and this is when we get into the discussions that we had in the symposium about risk stratification. So, for example, it used to be held based on the old RTOG 9802 study that patients were categorized as low risk if they were less than 40 and had a gross total resection of a classic low-grade glioma. Now, this was before molecular stratification was used. And in a patient, for example, who was over the age of 40 but had a gross total resection and a favorable profile histologically, that patient was put into a treatment category where they received PCV plus or minus radiation. And in 2014, the first IDH inhibitor clinical trials began, and this led ultimately to the phase 3 Indigo trial that we'll talk about. But the bottom line is that we need now, in the molecular era, we need to redefine risk. My colleague, Dr. Macarena de la Fuente, then began her discussion on the treatment options, and again emphasized that historically for patients who had the IDH mutated, whether it's one or two or both mutations for IDH, astrocytic versus oligodendroglial based upon the classification I stated at the beginning of this talk, those patients were typically watched and observed, especially if they were less than 40 years of age. If they were over 40, regardless of the extent of resection and the histology, they were deemed to be high risk, and they received radiation therapy and PCV or procarbazine, cysteine, and vincristine, and that resulted in a higher rate of overall survival than patients who are stratified by that risk who are not offered RT and PCV. Now, of course, radiation therapy and PCV has its issues, has its potential complications. So, of course, the community at large was looking for better strategies in those patients who could not achieve a watch and wait profile based upon extent of resection. And that's what Dr. De La Fuente began to talk about. With the discovery of the IDH mutations, this led to the identification of the oncometabolite 2-hydroxyglutarate. This results in a number of different issues for patients who have these gliomas, such as immunosuppression, epigenetic dysregulation, which affects gene transcription, etc. And so this was I think, a very important moment in the field of low-grade gliomas because it described a new biomarker, if you will, of the IDH mutation. And efforts are now underway and have been successful to identify this mutation using imaging, although we're not going to talk about that specifically, primarily through spectroscopy. Then came the advent of the early phase trials of IDH inhibitors. And for non-enhancing tumors, it was clear that the response rates and the progression-free survival were better than when used for the enhancing tumors. So this has become a focal point in terms of which patients, as we go forward, are better suited to the IDH inhibitors, meaning if they're enhancing or non-enhancing. But overall, these early phase clinical trials of these inhibitors showed that single agent IDH inhibition using these inhibitors improved outcome at earlier stages in the disease. And in comparing the ivosidenib, which was the precursor to the vorasidenib, and this was given in different doses. For example, the vorasidenib was given at 50 milligrams versus 500 milligrams of ivosidenib. And this was done primarily for low-grade gliomas, and then the dose was reduced to 10 milligrams of vora versus 250 milligrams of ivosidenib. And this was given preoperatively, and it was done strategically this way so that the appropriate pharmacokinetics and pharmacodynamics could be done. And basically what this showed was that vorasidenib was better in terms of brain penetration and target engagement to lower 2-HG, which was consistent with the tumor responses that were seen on imaging in those patients who were in these early phase clinical trials. So essentially at this point in time, these studies led to the decision that vorasidenib was the drug to move forward with in a phase 3 fashion. And that resulted in the Indigo trial, which was a phase 3 study involving IDH mutated grade 2 oligodendrogliomas or astrocytomas who only had prior surgery. They had non-enhancing measurable tumor. The vorasidenib was given 40 milligrams daily for 28 days versus placebo. There was a crossover at the time of progression in the placebo group, which of course eliminates the potential for the Indigo trial to give us information about overall survival. But it was a very robust study. 331 patients were randomly assigned. There were no grade 3 tumors. There were no prior treatments allowed. Patients who had refractory epilepsy were eliminated. And interestingly enough, they were treated between 1 and 5 years. So a lot of the so-called imaging findings that are confusing, that occur early after surgery, were allowed to be eliminated. And so this really showed true patients with progression or residual tumor between 1 and 5 years after surgery. And the endpoints of the study were progression-free survival and the time to next intervention, also demonstrated on the slides as TTNI. So PFS, TTNI were the endpoints. The median progression-free survival was 27.7 months in the VOR group versus 11 months in the placebo group. And there was also a longer TTNI, or time to next intervention, with the VORA group. The results were for this disease. It was, I think, a very important moment in neuro-oncology in terms of treating low-grade tumors that an IDH inhibitor, in other words, affecting the metabolic profile of the tumor, could actually reverse progression. And this was shown in the growth rate analysis as well. But overall, if you looked at the subgroup analysis, the progression-free survival benefit with vorasidenib occurred regardless of age, regardless of where these patients were located around the world. regardless of the time from surgery in that 1 to 5 year interval, uh, to the point where they were randomized. And another interesting thing, certainly for those of us who are surgeons, was the fact that the larger tumors, because a lot of times due to functional relevance, we have to leave certain segments of tumor in place to make it safe. And it was clear that tumors that were greater than 2 centimeters in diameter actually did better in terms of their response to vorasidenib. So this was very, very encouraging. Um, and so that piece will be followed in the future to make sure that that holds up. I think the other thing that was very impressive, if you looked at this data that Macarena showed us, was that the growth rate was significantly different, meaning that the mean growth rate decreased by 2.5% every 6 months in volume. And this is in contrast to an increase of nearly 15% in volume in the placebo group. So this was fairly dramatic, as it was demonstrated by imaging studies. The safety profile was excellent, and short of reversible changes in various um, liver function tests, this was a pretty well treated or tolerated drug. I think the other thing that was looked at, just in terms of subgroup analysis, was not in a significant way, meaning in terms of the hard numbers initially, but the seizure incidence decreased on vorasidenib. And this was looked at later with the numbers where it was shown that the reduction in the number of seizures in the Vora group, I think, was somewhere in the order of 3 or 4-fold reduced compared to the placebo group. So one of the issues that we all wondered in the beginning is whether or not this drug would affect seizures, and clearly it does seem to do that. So with all this in mind, this led to FDA approval in 2024. And the approval was for patients greater than 12 years of age who had the IDH mutation. They were grade 2. Again, we don't have data on the grade 3 patients. And this was approved after any degree of surgery. And I think it's important to just point out for a moment that in this study that was originally done in the Indigo study, there was measurable disease. And it was either residual disease or it was progression. But the reality is that we didn't have patients who had essentially a gross total resection being put on Vora. So in this label, it is possible, if you do a complete resection and you want to put the patient on vorasidenib, you're allowed to do so. This would be approved by the FDA with any degree of surgery. So it begs the question, who really should be on vorasidenib? I think, at any time point after surgery, regardless of extent of resection, patients technically could be on it. I mean, they should have grade 2 tumors. They should be non-enhancing. The questions that loom for us is, what about enhancing tumors or minimally enhancing tumors? What about tumors that are grade 3 that are not enhancing? What about patients who have refractory seizures who don't undergo surgery to deal with the seizure disorder? And does that change the definition of the risk stratification? But I think the overarching theme here is that patients going forward should have, based on all recommendations from all neuro-oncologies, a safe maximal resection. That means all flare-related disease should be removed if it is safely possible to do so. Also, if it is safely possible, patients should have a super total resection. If the patient has a complete imaging-based resection, you could, as the treating physician, still go back to the standard which we had previously, where you could observe those patients, or you could put them on an IDH inhibitor. Whether or not that's going to make a difference in terms of recurrence profiles, if they have no measurable disease, whether that's going to make a difference in terms of malignant transformation, if they have no measurable disease or even residual disease, we don't know what effect the IDH inhibitor will have on malignant transformation. So we have a choice now. We can put those patients who have grade 2 IDH mutated tumors, no other worrisome features like enhancing disease, grade 3 disease. We can put them on Vora or we can observe. But I think for any patient who has residual disease, if it's minimal residual disease, there's no downside to putting those patients on vorasidenib, meaning the IDH inhibitor. Could you watch those patients? Yes. Are they going to progress? Absolutely, unequivocally, in 100% of circumstances, those patients are going to progress. So is there a reason to wait until they progress? Well, we know from the Indigo study that they will get a response in the majority of patients. So if the treating physician or the patient decided to wait with residual disease, then the likelihood is they will get a response, as was seen in the Indigo study. But I think you have to ask the question, why wait for the obvious? Why wait for progression when you have a drug that is safe, can be taken chronically, has a positive effect on seizures, and could keep the residual tumor in check for long periods of time, for years and years and years. And so this is, I think, the new age we're going into. But basically, I think any patient with residual disease should be considered for treatment with vorasidenib. Now, it should also be known, and Macarena pointed this out, that ivosidenib has been shown to be effective in tumors that are enhancing, that are grade 3. I think you're going to see more and more patients that are going to be treated off-label for grade 3 tumors or enhancing tumors at the discretion of the physician. If the drug can be used in that way. Again, it's not part of the label, but it's up to the discretion of the patient and the physician to treat off-label if they so choose to do so, which is what's done with many drugs currently in the neuro-oncology space. There are a lot of new ongoing studies with vorasidenib and other agents, peptide vaccines, checkpoint inhibitors like pembrolizumab. So we'll see whether or not any of these combinatorial therapies is efficacious. So bottom line, I would say, is that based on everything we've discussed, we are in a new era. We're in the molecular era of defining IDH mutated tumors that are low grade. And these tumors are amenable for a new treatment with IDH inhibitors that are brain penetrant, reduce growth rate, reduce seizures, and it's safe compared to the effects we've seen long-term with radiation therapy and PCV. Please understand we don't know about overall survival. We don't know about malignant transformation. We will learn that as these studies evolve. And we're also going to see now a whole new set of studies that are going to really help us with understanding whether combinations are effective. So we ended this with the conclusion of the patient's journey. He was put on the IDH inhibitor. And I think this created a whole different profile in terms of hope, that he's been given access to the IDH inhibitor in a setting where he had residual disease, and now, based on the Indigo study, is very encouraged and has a brighter future because of this new treatment profile with the IDH inhibitors. So I will conclude at this point in time. I appreciate being part of this um, symposium with my colleagues, Dr. De La Fuente and Dr. Lim. And it was a very rewarding experience. We had a lot of great questions from the audience, and I'll leave it at that. And thank you for your attention.